Good morning and welcome to Grand Rounds. I'm so happy today and honored to be introducing Walter Schiffer. I'm his APD and really proud of all of his accomplishments, and I've really enjoyed getting to know him over the last 2 years, I should say. Walter comes to us from Texas. He graduated from Middlebury College with a degree in English and American Literature. He graduated from the McGovern Medical School, the University of Texas at Houston. He graduated AOA and came to St. Louis. I actually learned about Walter, interestingly, through his wife, who I've not met in person, but I know a work colleague of hers. And when they first moved to St. Louis, I was speaking to this colleague of his wife. He said, do you know Walter Schiffer? And I said, I think he's actually in my advisory group. I'm looking forward to getting to know him. He said, well, his wife is amazing. And we're really lucky that they came to St. Louis because she's, I guess, as impressive in the finance industry as Walter is in medicine. So they are quite the power couple. And I think we're really fortunate to have them in St. Louis. And I look forward to seeing what they do in their respective fields in the future. So today, Walter is going to talk to us about detecting a stealthy infiltrator, the clinical diagnosis of cardiac amyloid. Walter.
Thanks so much, Dr. Cow. So yeah, my name is Walter. I'm going to be talking about clinical diagnosis of cardiac amyloid today. So a few learning points to start out with. So by the end of the presentation, I hope you'll be able to identify some common clinical manifestations of cardiac amyloidosis, be able to distinguish the major types, recognize some suggestive echocardiographic findings, be able to take the initial steps in the clinical evaluation, and then I hope you'll be able to appreciate some of the disparities in evaluation and outcomes that affect our patients. So we'll start off with a clinical vignette. Miss Amy Lloyd is a 77-year-old woman. She has a history of non-ischemic cardiomyopathy and HFpEF, initially attributed to hypertension. She's coming into clinic after having multiple hospitalizations over the past year. She says she's not doing as well at home. She says that when she takes her blood pressure medication, she gets dizzy and lightheaded. And she did have her previous ischemic evaluation years ago, which was negative. So her blood pressure today is about 110/65, and that's not on blood pressure medications. And otherwise, her vitals are stable. So this vignette describes a real patient who was referred to cardio-oncology clinic recently and represents a not uncommon clinical scenario where patients reach pretty severe heart failure before being fully evaluated. So by the end of the presentation, I hope I can convince you that this situation is potentially avoidable with better screening, and we'll actually use our clinical vignette to go through the diagnostic algorithm for cardiac amyloid. So cardiac amyloidosis does remain underdiagnosed. It's thought that about 100,000 patients in the US have the disease, with 4,000 cases or so being diagnosed annually. But this is only thought to represent a fraction of the total number of patients who actually have the disease. It's thought to be present in about 13 to 17% of patients with HFpEF, 16% of those patients undergoing TAVR, 5% of patients who were initially diagnosed as hypertrophic cardiomyopathy. And this graph on the right is trying to illustrate the increase in prevalence and incidence of the disease between 2000 and 2012. And I think that's likely because of better awareness by physicians in diagnosing the disease, but we still have a little ways to go. Another epidemiologic point that I'd like to point out is that transthyretin is very male predominant, so 20-to-1 men to women, whereas light chain amyloidosis is about even. So a little bit of background on which types of amyloid affect the heart. So the two most clinically relevant types are light chain and transthyretin. AA is an inflammatory protein that can be seen in hyperinflammatory illnesses, including rheumatologic ones, but it rarely affects the heart. And then isolated atrial amyloidosis is another clinical entity that's usually clinically silent, so we won't talk about the latter two quite as much today. So light chain amyloidosis is the product of clonal plasma cells, which make light chains that then aggregate and deposit into multiple tissues. That includes the heart, the nerves, the kidneys, digestive tract, and up to 75% of patients with light chain amyloidosis do develop some kind of cardiac involvement. So, very predominantly cardiac in nature. And what's interesting here is that a large number of clonal cells or light chains are not necessarily needed to produce pathology. So you don't necessarily need to have multiple myeloma to develop light chain amyloidosis. Transthyretin, on the other hand, is a normal protein that's produced by the liver its major role is to transport retinol, has a minor role for transporting thyroxine in the serum. And depending on which mutation you have, basically they all lead to this breaking apart of the transthyretin protein, which reform into fibrils and then that deposits in the tissues. So they're hereditary and wild type forms. And what's interesting about this is that many of them many patients do develop some kind of small fiber neuropathy in addition to heart symptoms. Looking at hereditary transthyretin in specific, it's a pretty rare disease. It's autosomal dominant, but has incomplete penetrance. There are over 100 disease-associated mutations. And depending on which one you get, it can be primarily cardiac, primarily neurologic, in pathology, or it can be mixed. And then if you look at this pie graph on the left, you can see the breakdown of the mutations affecting our population here in the US. It looks like about 50% of patients have a de novo or wild type mutation. And then about a quarter of patients have this valine to isoleucine mutation. And it's thought that up to 4% of African Americans actually have this mutation, placing them at very high risk for having cardiac amyloid. So what are some initial clues that might make you think about cardiac amyloidosis? Patients, at least initially, usually have heart failure with preserved ejection fraction. And then their systolic blood pressures are usually a little bit on the lower side, and up to 75% of patients. And this is not a perfect litmus test. 25% of patients will still be normotensive or even hypertensive. But a common clinical scenario is a patient was previously hypertensive, is now no longer able to tolerate their blood pressure medications. Low-level troponemia and the absence of ACS can also be indicative. And then one thing I'd like to highlight here, and what's represented in the image, is this QRS on EKG discordance with the wall thickness that you see on imaging. So if you look at the limb and especially the lateral precordial leads, you can see that those EKG voltages do not really match up with the thickness of the LV wall on echo. And that suggests that something's infiltrating the heart and making it thick as opposed to just hypertrophy. Other clinical signs you might see are unexplained AV block, and then otherwise any unexplained thickening of basically any chamber in the heart can kind of launch you into a diagnostic workup. So what are some non-cardiac clues? For both light chain and transthyretin amyloidosis, bilateral carpal tunnel is pretty prevalent. Autonomic dysfunction is common. Sensory polyneuropathy, biceps tendon rupture, and lumbar spinal stenosis can all be clues. For light chain in particular, it tends to be characterized by multi-organ involvement. So you get nephropathy, you get lots of proteinuria, you get soft tissue infiltration, GI infiltration, which can cause dysmotility. And then the things like periorbital purpura and macroglossia are highlighted in textbooks and can be fairly specific, but they're pretty rare, so you won't see those as often. So looking at some EKG features, what's important to note here is that no EKG feature is sensitive, so the absence of any one of these features is not going to allow you to rule out disease. And what this chart is trying to show is the prevalence in a cohort of almost 1,000 patients with amyloid, and basically noting which EKG features they had. You'll notice that low voltage is present only in a minority of patients. And this is true, that usually it's only present in advanced disease. Some other findings that you might see are abnormal voltage to mass ratio. So again, highlighting that discrepancy you might see between the voltage on EKG and the thickness you see on imaging. And then poor all-way progression and a pseudo-infarct pattern are things you can see, and especially in the absence of acute coronary syndrome or known ischemic heart disease, those can be suggestive. So what are some echocardiographic features? A lot of people have talked about apical sparing. And apical sparing is looking at the longitudinal strain and dividing it up into segments and looking at the apex as compared to the mid and basal segments. So with apical sparing, you usually have preserved longitudinal strain at the apex, whereas at the mid and basal segments, the strain is reduced. Other terms you might have heard for this are cherry on top or bullseye appearance. And the initial paper looking at this was by Phelan, and they reported a pretty good sensitivity and specificity for this one echocardiographic parameter. But what's important to point out is that this study was done as a case control analysis, and they were comparing patients with known cardiac amyloidosis with those with aortic stenosis and hypertrophic cardiomyopathy. So it was never really validated as a screening tool or diagnostic tool by itself. So as part of our research, we went ahead and asked, how well does apical sparing perform in a less selected cohort? So we took 103,000 echoes, and wound up with 451 reports, where there was echocardiographer concern for amyloid. There was some indication for apical sparing, like targetoid appearance or bullseye appearance, and those were the ones that had adequate strain analysis to analyze. Unfortunately, the majority of these patients didn't receive any further workup. But of the 100 where we could rule in or out cardiac amyloidosis, 71 patients ended up being positive, and 29 we were able to rule out cardiac amyloid. So we found that the sensitivity and specificity of this one test may be a little bit more modest than was initially thought. Using a traditional cutoff of 1, we found a sensitivity of 66% and a specificity of about 60%. And then you can maximize the diagnostic accuracy of this test if you increase a little bit to 1.13, a little bit more specificity. What we were thinking was that maybe if you used this one echocardiographic parameter in conjunction with others, it could be a more effective diagnostic tool. And so what we found was that patients with cardiac amyloid were more likely to have thicker interventricular septums, again, more likely to have apical sparing, an increased ejection fraction to strain ratio. And what that's getting at is that patients usually have a preserved ejection fraction with reduced strain, and then a septal apical basal strain ratio. And again, that's getting a little bit at apical sparing, but looking more specifically at the septum of the heart. And this idea of using multiple echocardiographic parameters has also been addressed by others. So a very recent paper just published this summer by Boldrini looked at things like relative wall thickness, diastolic dysfunction as measured by EDE prime ratio, RV function as measured by TAPSE, longitudinal strain, and again, septal apex to base strain ratio. And they gave each one of these parameters a weighted score. And depending on how many points you got, you could, if you had more than 8, it was fairly specific for cardiac amyloidosis. So greater than 8 conferred a specificity of 95 to 99%. If you had none of these echocardiographic parameters, it was fairly sensitive. So it's a sensitivity of about 98%. And then what they also looked at was how these echocardiographic findings evolve over time and over the course of the disease progression. So what this graph is looking at here, as you can see in blue, green, and yellow, the echocardiographic findings that progress through the different stages of the disease. Earlier on, you see early diastolic dysfunction. You see increased relative wall thickness, reductions in your longitudinal strain, and increases in your interventricular septal diameter. As you get further along, you see even worsening of your diastolic dysfunction, and that's when you start to see a relative apical sparing pattern emerge. And then as you get to severe stages of the illness, you start to see reductions in your ejection fraction, as well as right ventricular dysfunction. So now that we're better equipped to go back and diagnose Miss Amy Lloyd, let's readdress her case. So again, she's our 77-year-old who's coming in with progressive heart failure symptoms and multiple recent hospitalizations. So if you can see the EKG, what it illustrates is a first-degree AV block, pseudo-infarct pattern as manifested by multiple pathologic Q waves in V1 through V3. And again, she doesn't have any known ischemic disease. And she does not technically meet low voltage criteria, but if you look at her EKG voltages and you compare that to the thickness of her LV on echo, you can notice a discordance there. And then if you look at the strain analysis, you can see that there's an apical sparing pattern, and the echocardiographer also noted grade 3 diastolic dysfunction as well as reduced RV function. So now that we have a pretty high concern for cardiac amyloidosis, we can take what I think is probably the most important next step in the clinical diagnostic algorithm. So for this lady, we're not concerned that she has another infiltrated process like sarcoid. We don't think she has hypertrophic cardiomyopathy or constricted pericarditis. So we're going to go ahead and do the serum capital lambda free light chain ratio and then immunofixation. And altogether, these 3 tests, when combined, confer greater than 99% sensitivity for light chain. So if it's negative, we're pretty confident in being able to rule out the disease. And so for Miss Lloyd, we go ahead and we do those tests, and reassuringly, her capital lambda ratio is normal, and her IFE is negative for any kind of monoclonal protein. So then we go to the next step in trying to confirm a diagnosis of what we suspect is transthyretin cardiac amyloidosis. And that next step is a technetium pyrophosphate scan. And essentially what that is it uses a tracer. We're not exactly sure how it binds to these infiltrated myocardial cells. We think it might be microcalcifications, But either way, it's fairly sensitive and specific for transthyretin in particular, especially for grade 2 or grade 3 involvement. One of the most important steps, which we've already done, is ruling out light chain amyloidosis for our patient. And then looking at the grading scheme here, you can see what you're looking at is how well the heart lights up as compared to the contralateral side of the chest. So on the top row, you can see that over the course of grade 0 to 3, the heart lights up more and more compared to the other side of the chest. And then the SPECT imaging or the transverse imaging is pretty crucial to rule out blood pooling as a potential false positive. So you're actually looking at the LV and you're trying to find the myocardium itself highlighting as opposed to the blood pool within the LV. And what's important here as well is that if the pyrophosphate scan is negative, it's not a perfect test. So you probably still need a biopsy if your clinical suspicion is high. So for Miss Amy Lloyd, unsurprisingly, her pyrophosphate scan is markedly positive. And we get the SPECT imaging to show that we don't think it's just simply blood pooling. So we diagnose her with transthyretin cardiac amyloidosis. And the next important step for her is going to be to undergo genetic testing to see if she has a mutation that maybe she passed along to her kids so that they can get better screening and potentially earlier treatment. So cardiac amyloidosis does confer pretty high morbidity. In one study of Japanese patients, they found that 80% died from cardiovascular complications of the disease. So the patients that do get this disease do tend to die of cardiovascular problems. And then AL, or light chain amyloidosis, is pretty rapidly progressive. So a quarter of patients die within 6 months of their diagnosis. Transthyretin is a little bit more slowly progressive, but still a quarter of patients die within 2 years of their initial diagnosis. So it's really important to diagnose these patients as early as possible. And one of the reasons for that is because now there are new available treatments for transthyretin in particular. And one that I'd like to highlight here is tafamidis. Tafamidis is a drug that stabilizes the transthyretin tetramer, prevents it from dissociating and then reaggregating in the fibrils, which then deposit into the heart. And there was a recent New England Journal study that just looked at efficacy, and it found that it improved not only the quality of life of patients, but also decreased mortality. So a last thing I'd like to highlight is disparities in both evaluation and outcomes. Both in our research and in research done nationally, it looks like Caucasians are more highly favored in getting fully evaluated. And then of the 451 patients that were eligible to undergo a complete workup for cardiac amyloidosis, a majority did not, and there was a higher prevalence in that group of African Americans. Patients with more cardiovascular comorbidities and end-stage renal disease were also less likely to be evaluated, and it may be reasonable not to do a full evaluation on someone who has really bad ischemic heart disease or has a poor prognosis otherwise. But we definitely need to do a better job of screening and doing a full workup for our African American patients, especially because they're at a higher risk of carrying one of these transthyretin mutations. And then on a national level, there was a study that looked at age-adjusted mortality, and it found that the mortality rate is twice as high for African American men compared to Caucasians. So looking towards the future, I hope that increased awareness about the disease will allow more equity in evaluation. And then there's also a new serum marker that's being analyzed. There was a recent study produced by the cardio-oncology group here looking at hepatocyte growth factor as a way to differentiate cardiac amyloidosis from other types of heart failure. And they found that it conferred a pretty good sensitivity and specificity in the small cohort. So it still needs to be further evaluated in larger cohorts, but could be a very useful test if you have someone coming in and you just want a quick test to try and differentiate if cardiac amyloid might be at work. Another future direction is that there's some automated echocardiography screening that's in the works. So essentially the EMR would look at some of these echocardiographic parameters, assign a score, and then create a pretest probability. And if it's high enough, it will alert the physician to maybe undergo some diagnosis or workup for cardiac amyloid. So with that, I will leave it up to questions. Oh, questions at the end.
I'll leave it to you to, let's see.
If you still had time to answer questions for the Q&A for this presentation, there's a question in the chat from one of the attendees.
Oh, great, yeah. No presentation. Okay. Dr. Gage will let you introduce Dr. Ellis here.
Our next speaker is Dr. Haley Ellis. She did her undergraduate at McGill University. She went to medical school at University College Dublin, where she was honored with the All-Ireland Medical Summit Researcher of the Year Award. She is pursuing a fellowship in hematology oncology, and I hope she stays here. Dr. Ellis.
Good morning. Thank you, Dr. Gage, for the introduction. I appreciate the opportunity to present a very basic overview of this field of research, liquid biopsies in cancer. I have no financial disclosures. Today, I'll discuss the advantages and limitations of liquid biopsies, provide examples of potential clinical applications, briefly touch on some of my research, and discuss future directions of this field. Historically, most medical treatments have been designed to treat the average patient. This one-size-fits-all approach has resulted in treatments that work well for some patients and not so well for others. Precision medicine aims to tailor treatment strategies according to the genetic characteristics of the patient's tumor. And in order to characterize the tumor and identify potential therapeutic targets, we need to be able to accurately assess material from the tumor. Tissue biopsies represent the current gold standard for cancer diagnosis and molecular profiling to help us guide selection of therapies. And though they're highly informative, traditional tumor biopsies have several drawbacks. Due to their inherently invasive nature, they can pose risk to patients with potential procedural complications and pain. Some tumors aren't easily accessible, so performing a biopsy may not be feasible. And even if it is possible, we may not be able to collect enough tissue for molecular testing. Importantly, biopsy of a single tumor lesion only gives a snapshot of alterations at that specific location and time. So it may not fully capture the complete genomic landscape within a patient's tumor or tumors. And finally, it's a less practical means to monitor tumors serially over time. And that's where liquid biopsies come in. This is an emerging tool that's drawn a lot of interest in recent years that shows some promise to overcome some of the limitations that are associated with tissue biopsies that I just described, either as an adjunct to standard biopsies or in some cases a potential alternative approach. It's a minimally invasive method for disease profiling that involves the isolation and analysis of tumor-derived material that's circulating in the blood or other bodily fluids. And given that a liquid biopsy may only involve a simple blood draw, it's arguably a more practical approach for providing insight into the real-time dynamics of tumor heterogeneity and evolution via serial monitoring. So there are several elements of liquid biopsy that can be assessed, though I'll only focus this review on circulating tumor DNA or CTDNA in the blood. All cells, including malignant cells, shed DNA into the blood. The term CellFree DNA, cfDNA, was first reported back in 1948 and refers to small fragmented DNA that's released into the bloodstream. As shown in this graphic, CTDNA is a component of cell-free DNA that's released from tumor cells, and its levels can vary greatly from less than 0.1% to maybe more than 10% of the total cell-free DNA, based on factors like tumor burden, stage, and type. So we know CTDNA is present in blood. How do we isolate and study it? Reliable detection and analysis is a pretty big challenge because ctDNA has a short half-life and it's at very low concentrations amidst a very large background of normal cell-free DNA, usually on the order of less than 1%. So successful isolation of ctDNA requires rapid processing and highly sensitive assays to quantitate the amount of ctDNA and be able to detect clinically relevant mutations. Analytical approaches have mostly shifted now to next generation sequencing based methods, ranging from targeted gene panels to whole genome sequencing. And what NGS allows for is massively parallel sequencing and interrogation of multiple cancer-related alterations. Importantly, there are a number of sophisticated techniques that have been able to improve the limits of sensitivity or detection for ctDNA. So the ability to analyze tumor-derived DNA from a simple blood draw has many potential clinical applications in cancer patients, including early detection, identifying minimal residual disease, and monitoring treatment response. I'll review a few examples of each of these. So one of the, we know earlier detection of cancer improves survival, and I'll briefly talk about a couple of recent studies with preliminary data in this field. The DetectA Study was just published in Science on the 3rd of July. And what they did was evaluate the feasibility and safety of combining a multi-cancer ctDNA test called CancerSeq with PET-CT and integrated this approach with standard screening to detect cancers. They assessed 9,900 women between the ages of 65 and 75 without a history of cancer or symptoms. And over 12 months of follow-up, they detected 96 cancers, of which 26 were first diagnosed by this blood test with high specificity. Notably, 65% were early stage cancers, enabling potentially curative treatment like surgery, and several detected cancers have no recommended screening tests. So these results suggest that this CancerSeq liquid biopsy could be a potential complement to standard screening to improve cancer detection. Another study by a company called Grail that's also focused on early cancer detection analyzed ctDNA from 6,700 patients with and without cancer. They found that their test was capable of detecting and localizing more than 50 types of cancer with high specificity and high accuracy to be able to pinpoint the tissue of origin. However, this sensitivity has a really broad range, as low as 39%, which isn't terribly surprising because early stage cancers have low levels of ctDNA and therefore are difficult to detect. There's actually a prospective multi-center trial ongoing to validate these findings in thousands of more patients. So screening is really probably top of the heap in terms of potential impact of liquid biopsy, but also probably the most challenging. Screening, as we all well know, requires high sensitivity and near perfect specificity, but this is certainly an area of research that's being heavily invested in. Minimal residual disease reflects a small amount of cancer persisting after treatment that can't be detected clinically or with imaging. Therefore, it represents an occult stage of disease progression or relapse. Detection and monitoring of MRD is established and widely used in patients with hematologic malignancies, but remains challenging in patients with solid tumors due to the difficulty in sampling low concentrations of ctDNA in blood. This image here highlights an example in locally advanced non-small cell lung cancer, but the point is that if patients have detectable ctDNA after curative intent treatment, they're very likely to recur or progress. So ideally, we want to be able to identify these patients with residual disease who are at high risk of relapse and be able to stratify them to adjuvant therapy or escalation of treatment to reduce their risk of disease recurrence and improve outcomes. If there's a lack of detectable ctDNA after treatment, these lower risk patients may benefit from de-escalation to reduce the risk of treatment toxicities and overtreatment. And another potential clinical application is response monitoring. The effectiveness of precision therapies can be limited by the eventual emergence of acquired resistance. We can use serial liquid biopsies to monitor for real-time changes in tumor dynamics, possibly even detecting these changes earlier than imaging or other markers, to assess response and or resistance to drugs and make therapy changes accordingly. And this feedback loop outlined here demonstrates the role of ctDNA in adapting therapy based on disease response. So in a very simplistic form, a patient receives, let's say, a targeted therapy. We can then analyze their ctDNA from a simple blood draw. If they're responding positively, for example, their ctDNA levels are decreasing, the patient can continue current therapy. If they're progressing, That would be if their CTDNA levels were increasing or we were detecting new mutations, we could change therapy. And a liquid biopsy test that's used currently in clinical practice is called Guardant 360. This is a commercially available platform that provides comprehensive genomic results from a blood draw based on evaluation of circulating tumor DNA. This test can analyze 74 clinically relevant genes for all the main types of alterations across a wide variety of advanced solid tumor types. And what you get from this liquid biopsy is a report of the mutations detected as well as available treatment options. That could be either approved therapies or clinical trials that's customized to the patient's specific tumor molecular profile. So for example, a patient with metastatic breast cancer progresses on a drug called ribociclib. The oncologist sends off the Guardant 360 test, which detects a PIK3CA alteration, and the patient is subsequently started on a clinical trial of a drug targeting this specific mutation. So now that you have a bit of a background of liquid biopsy, I'll provide some highlights of part of the research that I worked on during CSTAR, which focused on the role of liquid biopsy in identifying targeted therapy resistance for prostate cancer patients. Androgen receptor signaling plays an essential role in the development and progression of prostate cancer, which can be treated with AR-targeted therapies. The use of these drugs, however, is limited by eventual development of resistance. And alterations in this androgen receptor are associated with resistance to these drugs. We know that these patients with AR alterations do poorly. So how can we identify these patients with treatment resistance to be able to inform their therapeutic course better? Tissue is not always easy to get in prostate cancer, and imaging and PSA are not the most ideal either. There is a liquid biopsy test that's currently in practice, but the sensitivity is really poor. Thereby, it's likely missing a lot of patients who are resistant to treatment. So our question was, can we predict resistance to these AR-targeted therapies in metastatic prostate cancer patients by tracking AR alterations in a liquid biopsy? We developed a novel liquid biopsy assay called EnhancerSeq to detect AR alterations in CellFree DNA. We then used this liquid biopsy prospectively on 40 patients with metastatic prostate cancer that were treated with AR-targeted therapies. And the answer to our hypothesis was yes, we can use a new liquid biopsy to identify patients with resistance to these drugs earlier and more sensitively than the current blood-based test. We identified 78 to 89% of patients that developed treatment resistance, and the range depends on if we looked at patients who had primary resistance, which means they never had any response, or secondary resistance to these drugs, where they had some initial benefit, but then eventually progressed. And the key finding here was that these patients with AR alterations detected on liquid biopsy are strongly associated with treatment resistance, and these patients have significantly worse survival outcomes as demonstrated by the Kaplan-Meier curves. So the message here is that we could use liquid biopsy as a tool to identify patients that are high risk for developing treatment resistance to AR therapies earlier and more accurately, thereby enabling clinicians to consider alternative or more personalized strategies. And there's still ongoing work that's being done to validate these results in a larger cohort. This was recently published study from 2 weeks ago, which has created a bit of buzz. This was a longitudinal study that included 123,000 healthy asymptomatic individuals from China. They actually needed a warehouse to store the 1.6 million samples. They collected baseline plasma samples and then followed these patients over 10 years to monitor for cancer occurrence. And preliminary data from this CTDNA test called PanSeer shows that it can detect whether an individual has one of 5 common cancers 4 years before conventional diagnosis. And what PanSeer does is it looks for CTDNA methylation markers to detect stomach, esophageal, colorectal, lung, and liver cancers, which are common in China. And the cancer detection specificity and sensitivity is actually quite high. Now, this test certainly needs to be further validated in additional studies, but the prospect of identifying cancers several years prior to conventional diagnosis is certainly very exciting. in that it's likely identifying individuals who already have cancerous growth, but remain asymptomatic to current detection methods and standard of care. So in summary, liquid biopsies represent an emerging approach for molecular profiling of tumors, either as an adjunct or maybe an alternative to tissue biopsies. It's a minimally invasive method to possibly better serially monitor tumor dynamics. And there are many potential clinical applications, including early cancer detection, response monitoring, identifying MRD, etc. And as the science of liquid biopsies continues to advance, liquid biopsy-based assays can provide a snapshot of what's going on inside a tumor without actually having to go inside the tumor. So thank you very much to Dr. Fraser, Dr. Costco, our APDs, and great chief turnout here, and Dr. Gage, Dr. Chaudhry, and Dr. Chauhan. Thank you.
Okay, thank you everyone for being here this morning. We have a few questions coming in. I'm going to invite Walter Schiffer back up to the podium so we can go through some of these questions together. We'll start with Walter. One question that we had was, have we made any efforts to standardize the way this is evaluated for or reported on our echo reports, this referring to cardiac amyloid?
Yeah, that's an area of ongoing research. There's not really a standard way of going about it, unfortunately. And it's been much discussed in the cardiovascular division because not all patients are able to get strain analysis. And it's actually not mandatory for that to be reported in the echocardiograph, in the echo report. So that's in the works. I think that we're trying to encourage a more standardized way of putting that in so that strain can be assessed on every patient. But that's a really good question, and it's something that needs to be worked on.
Okay. Thanks, Walter. One more question for you. Is the progression or prognosis of AL cardiac amyloid worse than transthyretin cardiac amyloid, or does it have worse systemic manifestations?
Yeah, so I think patients with light chain amyloidosis do tend to progress in terms of their cardiovascular symptoms much more rapidly, and they do usually die from cardiovascular manifestations. But it can be a very heterogeneous disease process. So some patients have predominantly renal findings initially, but yeah, a lot of patients do end up dying because of cardiovascular complications of the disease, and it's much more rapidly progressive than TTR by comparison. I think within 6 months, a number of patients usually die. I'm not sure. I think that answers the question.
Thank you, Walter. Okay, we'll shift on a little bit more to questions for Haley here. One question that we have is, how do the AR mutations that you found in prostate cancer compare to the ER mutations that are found in breast cancer?
So as I stated, the AR mutations in prostate cancer are associated with resistance to AR targeted therapies. And I believe there are some studies in metastatic breast cancer looking at ESR1 mutations in CTDNA that are associated with resistance to endocrine therapies. So certainly there's a lot of sort of cross-tumor applicability for liquid biopsies.
And then one other question that came our way is, any studies or data on identifying tumor neoantigens or mutational changes in the tumor that could be targeted in the future?
Great question, Dr. Shim. There is some sort of newer data that's being done on assessing tumor mutational burden in liquid biopsies. So that would be a helpful marker for patients for immunotherapy, which is, the indications are continually being expanded. So that would certainly be a benefit as well. Though there's certainly other mutations that are being assessed as well.
Okay, I think that concludes our question and answer session for now. Again, I want to thank Dr. Haley Ellis and Dr. Walter Schiffer for joining us this morning to start off our SAR Grand Round series. And thank you to all of you who tuned in this morning to listen to their talks, presenting their work that they've done throughout our residency. We'll continue next week with our Grand Round series. If you guys have any further questions for these two speakers, feel free to send them to the speakers themselves or to me, and I'm happy to send them along. Thank you.